Morning, everybody. Thanks for joining us this morning for the Falls Forum. Just a few housekeeping points as we start. Make sure everyone to stay muted so everyone has got a good listening experience. We're going to try and keep this to 45 minutes as normal, so it's not too long. If anybody's got any questions as we go, please put them in the chat box. I'll be monitoring that, and we'll try and get as many of those answered as we can. So what are we here for today? We've got James Gough from the Welsh Ambulance Service joining us, and we're going to learn about the magnitude of the falls issue, and we're going to gain some confidence on when and when not to lift fallen people, and how we can lessen the burden for ambulance services and make falls less of a headache. So I'm going to welcome James Gough from the Welsh Ambulance Service. He's the Falls Improvement Lead. He's been part of a fantastic new falls framework that's been put into place by Welsh Ambulance Service, and it's all the other ambulance services across the UK have taken note, and there's widespread support right way across the UK. The figures he's going to be giving us are across Wales, so those are going to be, that's just for that section of the UK, but I would imagine they are indicative of the whole of the rest of the UK. So with that, I'll hand over to James, and he will take us through his content for the day.
Thank you, Harvey. Hiya all. Talking to you from sunny South Wales, very sunny today. I hope you're all well. Thank you for joining, well, thanks for giving me the opportunity really to speak today. It's fantastic. Just by a means of introduction, so I'm a paramedic, been registered as a paramedic for 10 years. I've had various roles across the trust in very much operational command type roles, very clinical, so remained a paramedic throughout my whole sort of career, and as of 2014 I've got involved in a lot of quality improvement work, particularly around falls initiatives, so falls response initiatives. So back in 2014 I started a very small team with a group of colleagues, having paramedics and physiotherapists working together on an emergency ambulance. And back in 2014, when I mentioned we're going to put physios on an ambulance, there was this, whoa, how are we going to do this? What about the governance? What about this? We worked through a lot of challenges, and I like to say that now we've got a really strong framework, falls framework, that we are starting to roll out some of these initiatives across the whole of Wales. I've been lucky enough to be provided with the opportunity to contribute to the National Guidance for Paramedics, which is the falls in older adults, and this is through the Joint Royal College of Ambulance Liaison Committee. This guideline is one of the sort of foundation guidelines that all paramedics and the majority of pre-hospital care providers follow when they're assessing patients who have fallen. So it's been a whirlwind couple of years, and I've enjoyed every single minute of working with colleagues across the settings, whether that be care homes, whether it be OTs, physiotherapists, community-based services, urgent care services, and of course my employer and my employing organisation, the Ambulance Service. So today I thought it'd be a really good opportunity to set the scene with regards to the ambulance demand, and then go through briefly around the Welsh Ambulance Service story, about what led to our quality improvement initiatives, why we felt the need to change and why we actually needed to change, and then some of the work that we've been carrying out with our care home settings, and some of the work that we've been carrying out with community-based services. So I think the good place to start will be around the demand, and this, I've got no doubt, is exactly the same across the UK. So when I speak at some conferences, I always ask the question, how many falls do we have a year? And we have some really wacky figures, the falls are the second highest category of calls that come through to the ambulance service, second only to shortness of breath, breathing difficulties. We have, on average, up to, and last year being the average, we have 60,000 falls-related incidents in a year period across Wales. Now, that equates to close on 100, we have the 60,000 incidents, but equating to about 20, well, we've seen about 2,500 of those. So out of the 60,000 that we have, 2,500 of those incidents are classified as categorically non-injury falls. Now, when we think of that, that's only 6% of the total figure. 6% of all the calls we receive are categorized as non-injury. And that's because, we've started to see, as an ambulance service, things becoming a bit more complex. Sometimes patients waiting a long period of time before they contact the ambulance service. Sometimes patients remaining on the floor for quite some time before contacting the ambulance service. And there could be many reasons behind that. But we're noticing a lot of complexity around mobility, around functional status, and, quite an increase in the medical acuity of patients. But there is a but. What I would say is, the demand of 2,500 calls per year for non-injury falls, sometimes patients who form in this category, they come under our clinical prioritization system. And if you're not hurt and you contact the ambulance service, you may have to wait a little bit longer for an ambulance response. And that's because, we are dealing as an ambulance service with strokes, with heart attacks, with people who stop breathing. And for some of those patients who are not hurt, they will form part of the lower clinical prioritization system. But in 2016, and this is where I suppose, our journey changed, we recognized that for these 2,500 patients who were not hurt, they were actually coming to significant harm. And that was because, our serious adverse incident profile was in the majority for patients who first started their journey with the ambulance service as contacting us for a non-injury fall. And I think, as an organization, that was really hard to see, really difficult to see that patients had come to this, to some harm because of the fact that they have been waiting so long for an ambulance response. And back in 2016, we were in a situation as a service where people waited many hours to be responded to by the ambulance service. So with the demand increasing, and it increases about 2 to 3% each year, and the complexity increasing, we recognised that we had to, or we was in a position as an ambulance service that we could do things differently. And we started talking about a falls framework and a falls response model. Now, I've got no doubt that all of you on this call today who have an interest in falls will really agree that, falls are complex. They are not in isolation. And I think as an ambulance service, we recognise that, yes, there are patients who are not hurt, and there are patients that are more complex and need a greater level of input. But if we just keep on sending a traditional ambulance response, then we are going to be in a situation where people are still going to be waiting for that ambulance to arrive. So we introduced the falls framework that had 5 levels, or 5 domains that we've called them. The first one is around prevention. So the ambulance service having a lot more sort of responsibility around meeting with national organisations like Public Health and around getting really involved in the prevention agenda for falls. Things like brief intervention training. So this is an example of where we help or we assist to provide some training to our non-emergency patient transport staff, or maybe we can provide training to the volunteers to assess risks for falls before the actual fall happens. Then we've got the second part of the domain, which is around supporting community resilience. So I'm going to stop there because this is a very important, I'm not going to stop, I'm going to keep on going, but this is a really important part of our falls framework. So supporting community resilience is about recognising that as an ambulance service, when we have 60,000 falls per year, there is a very limited possibility that we are going to be able to respond to everybody within the time that we wish to do. And you're probably aware that, in guidance, they've said now that an hour on the floor for a person is actually classified, anything longer than an hour is classified as a long lie. And that means that if someone remains on the floor for longer than an hour, then they will start to come to harm. And that could be pressure sores, it could be pressure damage areas, it could be, as we're talking about the wider skin integrity, we're talking about functional decline, psychological impacts about being on the floor for that length of time. So there are massive amounts of research that are showing that the longer someone stays on the floor, the worse their outcomes are going to be. So the community resilience is about recognizing that in the community, there are other organizations and other agencies that may be able to help lift people up off the floor. And I'll just paint a picture, on a standard day, a standard morning, across Wales, we could have up to 80 or 90 emergency calls waiting. And that would be a normal day. And for those patients who have fallen, who are not hurt, we now need to start working with others to make sure that we can get there quickly. One of our work streams is with the care home sector. So we're very lucky in Wales. We've got an ambulance service commissioner linked directly to Welsh Government. And they made a decision back last year to purchase lifting devices for every care home across Wales that wanted one. And they also made the decision nationally across Wales to then provide training and then to provide some guidance and support with the governance and around the policy setting for some of the care homes. And I think, as a clinician, I hear all the time when I go into care homes, we couldn't lift them because it's not our policy to lift. Or we've got a no lift policy. Or, our manager doesn't allow us to lift. And then our manager says, phone the ambulance. And I really started being quite simple in my messaging when I was speaking at some of the local forums around, we would not want someone to come to harm by leaving them on the floor. And actually, if we're aware that the ambulance is going to be a little bit longer getting to you, and we are aware that the ambulance service is stretched and they're really struggling to provide a response, it is the right thing to do to lift someone up off the floor when they are clearly not hurt. And that's the distinction. So we've gone around the whole of Wales and we've introduced, as I say, the lifting device, the training, and a tool in which people can assess patients or residents, clients, service users when they've had a fall. Now, this extends to care homes, domiciliary care providers, and some of the reablement staff, within the community resource teams, physios, OTs. This is a simple tool that we've taught in order to just follow to work out if someone's not hurt. So you may have heard of the I Stumble tool. So the I Stumble tool, and I'm not going to sort of endorse one tool. There are many tools available. We at WAST, we're actually trialing a new tool called I Fell Down. Ironic, suppose we're talking about falls. So the I Fell Down and the I Stumble tool, they're simple checklists for clarity that we can provide to non-clinical staff who can follow a brief checklist to work out if someone's not hurt. If an individual is not hurt, then we're able to refer them to the local community-based services. That could be so district nursing teams, GPs, sometimes 111 if further advice is required, or as a last resort, the ambulance service. And I think, what this does for us is it makes sure that the patients who are actually coming through to our system from care homes are those patients that are going to be requiring an ambulance response. Since we've started this trial, we carried out a real small test of change in 10 care homes in one area. And within 10 care homes, there were 1,000 related falls incidents in 1 year. So 1,000. Now, out of those patients, the significant majority of those would end up contacting 999 because, there was limited policies within the care homes to actually assess and then to refer on. So what we did, we put a training program in place, we put the iStumble tool in, and we provided the lifting device. And in those 10 care homes, this is only 10, it dropped our 999 call volume by 42%. Huge, huge. And, that's important for a few reasons. First of all, the patient or the resident gets up off the floor quickly and it reduces any further harm. Then secondly, the ambulances, which are limited, we've got limited capacity to respond, they are available for the higher acuity incidents within the community. And that's a marvelous example of supporting community resilience. The other side of community resilience is around developing our volunteers. So we have many volunteers who respond for the ambulance service as community first responders, and we've trained all of our community first responders to be able to lift patients up off the floor. So these are people who live local, who volunteer their time and give so freely to the ambulance service, but then are able to respond on our behalf to a patient when they have a non-injury fall. And then, we are starting to look at maybe domiciliary care. And there's some other complexities when we talk about domiciliary care around some of the governance, some of the local variation. But there is no reason to why, a domiciliary care provider would not be able to utilise the same tool that's used in the care home setting to lift patients prior to the ambulance responding to them, or in some instances, not responding at all. So, my message from the work that we've done with care homes is national change is really achievable. Within the space of a year, we've rolled out to hundreds of care homes. There's only been a few that have refused or not really accepted the gift of a lifting cushion and some of the associated training. But all of the staff have fully embraced the training, fully embraced the governance. And as an ambulance service, I think, sometimes in the past, we've been guilty of saying, you're a frequent caller. You contact us too many times without really understanding the reasons behind why that's happening. So we've had a lot of local engagement. We've had a lot of data sharing and a lot of understanding of, the challenges. Because as a clinician, it's easy for me to say that someone's not hurt. As a care member of staff or a domiciliary care provider, it might be a little bit more difficult. But I always say the simplest question to ask to any person is, are you hurt? And then the next question is, when they say no, do you want to get up? And it sounds very, very simple, but that is the thing that's going to reduce the further harm. So that's the community resilience part. What we are doing then within the Welsh Ambulance Service, we've recognised that there's a huge work around assessment, hear and treat. So our control room, they are taking thousands of calls every single year. And a small percentage, I say small, it's 12%, could be up to 15, they are falls related. So it's important that the control centre, the clinical centre, is able to identify what response patients are going to need. So for some patients who fall, they require a simple response, which will be someone to come and assess them, to provide a very quick medical assessment, and then to refer them on for a falls assessment. And we call this now a level 1 falls service. So we got 3 levels in Wales, and this is across the whole of Wales. We are still working on the level 2. but the level 1 is now fully implemented across the whole of Wales. So this is a brand new role for Ambulance World. This is called a Falls Assistant. And the Falls Assistant is provided in partnership with St John Ambulance, or St John Cymru Wales, because we're in Wales. The St John Falls Assistant is a non-registered role, but they are able to provide a basic assessment of blood sugar, temperature, pulse, blood pressure. So all those kind of stuff, you know, that we would need to make a bit of a reasonable decision about, you know, where that patient needs to be referred to. So the Falls Assistant we have across 7 health boards. So there are 7 trust equivalents, so health boards within Wales, and they have 1 Falls Assistant. Now they are able to respond immediately to the non-injury falls patients. And our prime aim is to make sure that we reduce the length of time that these patients wait on the floor. And as you can appreciate, you know, ambulances will be still going to the life-threatening incidents. Sometimes those patients can wait a lot longer, but by putting a designated response in, we can make sure that that those patients who have fallen, who are not hurt, can get a very quick response, prevent further harm. Then level 2, this is a paramedic and physio, or paramedic and OT. And we've trialed this in one area for about 4 years. And we're now at the stage where we want to increase this across Wales to make sure patients have a full medical and social assessment, along with functional and sort of mobility assessment. Now, this is for what we call complexity falls, complex falls. So this is not where, you know, where we have information to say that someone's not hurt, that will go straight to a falls assistant. But where we have doubt, and sometimes, you know, for a lot of patients who contact us, there's that doubt, there's that, you know, we can't get the right information, or we think that there may be an injury, or we think that there may be something else going on. So because of that, we send a falls team, and that's the paramedic and physio. Now, the results for this team have been fantastic. Over 80% of the patients normally remain at home. And around about 20% of patients get conveyed to hospital. To put that in perspective, normally around 50 to 60% of our patients get conveyed to hospital, and then 50% of patients then will remain at home. So we're actually keeping, on average, 80% of those patients at home. But that is through referring back to the community-based services. And then level 3, it's an obvious one, but an ambulance. Sometimes people need to go into hospital, but we recognise that may be, you know, specialist ambulances responding to patients who need to go perhaps following a hip fracture, or we need to have designated responses for different types of falls. And that's something that we're working on at the moment. So that's the 3 levels of response. And then finally, part of the falls framework is around reducing further harm. So this is recognizing that as a service, we have got a real duty in making sure that patients who are waiting for an ambulance response have the correct advice. And this is the correct advice. You know, for too long, we've been saying to people, do not eat or drink anything. Do not move. Keep still. And that is the wrong advice in the majority of the calls that we are going to and that we receive. Because for the majority of the patients, they need to move. They should move. They should drink. And yes, they should also eat. So we've changed our entire system that unless there's exceptional circumstances to why the patient shouldn't eat or shouldn't drink, then that's exactly the right thing to do. But that is clinically led. So we have a paramedic and a nurse who is able to give that advice within the control centre. So for me, you know, this has been a journey around collaboration and about partnership working and about real extensive engagement with care homes, with domiciliary care, with independent sectors, the St John Ambulance, with Welsh Government, you know, our commissioners, in understanding how do we improve this service to the patients that contact us via 999. Looking forward, we are now at the stage where we have rolled out the level 1 response. So everywhere across Wales, we have a falls assistant. Everywhere across Wales, we have community first responders who are able to respond to falls within their local community. Everywhere across Wales, we have now implemented sort of lifting devices into care homes. And then we've also introduced the training and the support and the ongoing support for the staff. What we need to do now is to really ramp up the response element, which is with the paramedics, the physiotherapists, and the occupational therapists, in understanding that there's a lot more complexity behind some of the patients who contact us for a fall. And that's what we're really concentrating on this year. Plenty more opportunities for collaboration, plenty more opportunities for development. I see a couple of questions around, is this being rolled out? And I'm having a really quick look at the chat box there. We've been linking in with NHS England, and there is early work underway to propose that some of the Welsh Ambulance Service Falls framework, which is a really simple framework, could be utilised across the board. And, you know, wouldn't it be lovely that we could say that across the whole of the UK, there would be a 3-leveled response to a fall. And there would be the concentration on developing the community resilience and the work within the community to help people lift patients from the floor. So what I would say is, you know, we're still on the journey. I'm more than happy to receive questions. And I'm also really happy to share data. I know there's a lot of discussion in the sort of chat box there. If anybody wants any specific data, I would welcome you to email me, and I would be more than happy to share some of the evaluation reports that we've undertaken as a Welsh Ambulance Service. So I suppose for me, that's what I've got to say as part of this webinar and about our journey. Which has been, you know, a really lovely journey over the last 4 years. And if there's any questions, I'm more than happy to take some now. Thank you, Harvey.
Thanks very much, James. That's fantastic. If anyone's got any questions for James, put them in the chat box, and we'll try and get as many of those answered as we can. One of the questions that I get a lot of the time when I'm talking about falls, either in the community or in care homes, is how do we know if somebody's got like a major injury, like a hip fracture? If they're lying on the floor, they might not feel that straight away. So if you ask them if they're hurt, they might say that they're uninjured, but they have got a fractured hip. What would you say to give people confidence in making that decision and whether they're good to lift or not?
So I would say, and I always start the training, as I said, with the basic question of, are you hurt? Yes or no, and that's a really good starting indicator. But the I Stumble tool is something that we recommend across the whole of Wales. And for colleagues who are not aware of the I Stumble tool, this was a tool that was designed for ambulance services in relation to assessing patients who are not injured following a fall. And the I Stumble tool really focuses on things such as intense pain. So, you know, asking someone, have you got any new pain since the fall? Have they had any suspected collapse? Has there been any trauma to the head, neck or back? Are they displaying any signs of unusual behaviour? And for some of our care home residents, it was very difficult when they were assessing patients with dementia. And, you know, this is around, is there any new confusion or any different unusual behaviour? And then we talk about in the training about, is there any difficulty in breathing or chest pain? Is there bleeding that's occurring that's severe? And then is there any loss of consciousness or a fracture? So that sounds a very simple tool, but it's very effective. And the I Stumble tool is very, very effective in just providing people with a checklist for clarity. And the checklist, you know, people are able to go through is simple and allows people to work out, do we need to contact the ambulance service on this occasion? And for the majority of times, and, you know, working clinically, I think for at least half of those patients that we go to, we can safely say that they could have been managed in a different way. And that means, you know, supported within the care home, supported within the community, but through the use of a recognised tool, such as the iStumble tool.
That's really, really good. So are you saying that 50% of those calls that you have had, the 60,000 calls that you have a year, you think if they were properly managed within the setting that those falls have taken place, that 50% of those wouldn't need an ambulance response?
Harvey, I think the main concern for me, and it was right at the start of this journey, was around the long lie. We were seeing incidences through serious adverse incident profiles of patients who had been waiting. The call had originated, at 8 or 9 o'clock in the night, and for all sorts of reasons, we were unable to get to that patient till the early hours of the morning. Now, it was quite obvious to the ambulance crews when they arrive at the scene that that patient could have, with the correct lifting equipment, with the correct training, with the correct governance and policies, could have been lifted from the floor. And I think that's so frustrating. Number one, the patient has potentially come to harm, but for the ambulance crews who actually turn up, they have to convey a patient to hospital who could have, if given the right set of circumstances, have been managed at home. And I think that's where we come from with the training, is that when we introduce a lifting cushion, when we introduce the training, it is about reducing that period of long lie. And as I said, anything over an hour is now classified as contributing to harm. We have to work out what services are out there, what other services are there to help us as an ambulance service to respond. And sometimes, taking ownership, providing some of the equipment, developing the policies, they're all key things in making sure that the person gets the best care.
That's really good. I can see a few questions coming through about the iStumble tool. We will put a link to that. It's an app you can download, but we'll put links to all that on a follow-up email that comes after this. There's a number of tools that are out there. James mentioned the iFall Down. There's one that has been developed in the Southwest Ambulance Trust. It's just a simple red, yellow, green flowchart. Very nice and easy. So it fits onto a one-page A4 sheet. Very nice and easy to go through. What would you say, James, for non-clinical people, let's say a domiciliary care worker who's gone to somebody's house and is nervous about whether to lift or not because of the litigation side of it? If they lift somebody and there is an injury and they cause further harm, what would you say to somebody that's got that conundrum?
So, I think using a recognised tool is definitely the way forward, and incorporating that into your policies and procedures. And a lot of organisations within Wales now have accepted that tool. The Healthcare Inspectorate for Wales, they've incorporated that tool, so it's something that they actively look for when they carry out some of the inspections within the care setting. For domiciliary care, it's traditionally been, really challenging, the fact that, they will have to remain with the patient for a significant amount of time, waiting for a suitable response to be sent. This is for the patient, for the staff as well. By lifting that person up from the floor quickly is going to ensure that A, they get from the floor and reduce further harm, and then B, for the carers, they're able to carry on with their normal day-to-day work. But I would say, from a legality perspective, we as an organisation deal with far more serious adverse incidents in relation to falls as a result of a long lie than anything else that we have, particularly within the falls category I'm talking specifically. And that means, that no matter, I think we have to balance the risk between someone laying on the floor for a significant amount of time and actually the risk of getting them up and possibly having a minor injury. And it's often not the injury that will cause harm. It is the fact that someone has been on the floor for such a significant amount of time. And it is the emotional aspects, the psychological aspects, and I'm talking regularly to people when we turn up on an ambulance or on a specified response unit that say, I didn't want to phone the ambulance service because I know that you're really busy. And the last time I had to wait such a long time. And that must be so scary to think that as an individual, you're almost setting yourself up to wait, and to have that psychological impact of waiting for a response. So I would say we've all got a duty, we've all got a responsibility, but it's about how do we work together to identify the training needs, then to provide the correct equipment, and then to ensure the correct governance. But myself, contact your ambulance service. There's bound to be some other James somewhere in some of the ambulance services across the UK. Use your ambulance services as a bit of a link. You know, they have some fantastic data to highlight the falls demand. They have some really good awareness of some of the local services, and I'm sure they would really want to work in partnership to develop some of these services.
That's very, very good. I know we're running a bit low on time now, so I'll crack on with a demonstration of the Raizer chair. It's one of many lifting devices out there. It's probably one of the lesser known ones, so we'll do a demonstration with that. Just one last point I think it would be good to make. If somebody is in the situation where they're unsure whether or not to lift, calling into 111, or perhaps if it's slightly more urgent, 999, you can get so much guidance over the phone as to when not to lift. The controllers in the 999 or even 111 response will give you so much guidance on whether to lift. If you've got some lifting equipment there and you've got a guidance protocol, but you just need that little bit of extra assurance, you can get so much help over the phone. And with that, I think we'll crack on with a demonstration of the Raizer chair. My colleague Ruben is going to have a full for me, and we'll show you how the Raizer chair works. So I'm going to skip through the section where we'll go through our falls protocol. He's not got any intense pain, he's not got any bleeding or any limb deformities, new limb deformities, so we know he's safe to lift. So what I'll do is I'll make him comfortable with a pillow. Tuck that on your head. Thank you. Then this is the Raizer chair. These two pieces here. So you've got a seat unit here. And we're going to make sure he can bend his knees, like so. So we can slip the seat unit underneath. Tuck it up nice and close to the thighs. Then in this bag here, we've got 6 different components. So we'll start off with the backrests. These are both, there's 2 of these, one for each side. They're totally interchangeable, so you can't get them the wrong way around. So what we'll do is we'll put this arm across the opposite shoulder. That lifts the shoulder blade, so you can tuck that underneath and click into the seat unit. Exactly the same the other side. This arm across the opposite shoulder, tuck it underneath and click into place. And you'll probably be able to hear a beeping noise. It will beep when you've got the components in the right place, just so you know it's clicked in properly. So I've got the 2 backrests in, and then you've got a strap here. Doesn't need to be too tight, just mainly for reassurance. Then we've got 4 of these lifting arms, 2 each side. Again, they're identical, so you can't get them mixed up. The one in there, and exactly the same the other side. When you get the last component in, I don't know if you can see from there, but there's an orange light on the end just there. When you get the last one in, that'll go green, and it'll give you a different tone to let you know that you've got all the pieces in the correct place. Like so. So now, we've popped the remote control out the side, it just is held in there via a magnet. We've just got a simple up and down button. So I'll support Ruben's head, press up, As soon as I take my finger off the button, it will stop. So I've stopped at a fairly comfortable seated position. A lot of people, when they first come up off the floor, might be a bit dizzy, might still be a bit anxious, might need to get their bearings for a bit. So we can get him a cup of tea, make sure he's comfortable, got his bearings. Then we can get a walking frame or a steady or something like that if he needs. And we can unclip the safety belt and go right the way up to like a perching position. Obviously, depending on the height, depends on how high you want to go. If it's somebody that's fairly short, you might want to stop there so they can mobilise. If they're taller, you might want to go right the way up to the top. Like so. And off you go. So that's a brief demonstration of the Raizer. If you want a more in-depth demonstration of that, then please get in touch after the demo, after the webinar, and we'll get something arranged for you. Have we got any further questions? Restrictions on the flooring. If you look on our YouTube channel, there's an interesting video on there. It's called the Surface Challenge. So we have done a lift on grass, gravel. We actually did one on the beach, which was, it still works. It just makes a slightly crunchy noise on the sand. But yeah, there's no restrictions. It can be used in the tarmac, lino, wooden floor tiles, long pile carpet. It works. Any other questions? Yep, you can stop the chair at any point. As soon as you take your finger off the button, it will stop. You can go back down. If you're starting to lift somebody and they're showing new signs of pain, indicating that there might be some further problems, then you can let them straight back down to the floor if needs be. Any other questions? The weight restriction, 150 kilos, that's 24 stone. And the cost of the Raizer, it's just over £3,000. So as an individual unit, it's 3,129 plus VAT. If there are any questions unanswered, we'll make sure they're answered in the email afterwards or directly. If you think of any more, then feel free to get in touch with myself. My contact details will be available as this webinar ends. So thank you very much for James for joining us. Some very valuable information given there. I hope everyone feels more confident in when and when not to lift, and feels enthused to try and take some pressure off ambulance services. So next week we have got Jill Crichton talking about ergonomic tools for assessing patients in the community. We've also got, in future weeks, we've got Anita Rush talking about the care of bariatric patients. Many other interesting subjects on the webinars coming up. So please stay tuned. Keep an eye out for the invites, and we look forward to seeing you in future occasions. In the email that follows, we've also got some information on an additional product that we are considering relating to falls. So please check that out. We'd love to see your opinions on that. I know everyone here is here because they've got a certain interest around falls. So do check that out and give us some feedback on that. So again, thank you very much for joining, and we'll see you again.